Okay, let's make a start. Welcome back. I hope you had a nice lunch. Usually what happens after lunch is you feel sleepy, which is not so great, but hopefully you'll stay awake for this. Okay, so now we have had some discussion already about the course, the contents. We've talked briefly about micro, meso, macro levels, which I'll come back to now. And we also have had some really stimulating inputs with regards to how you conceptualize the Indian health system. These posters, as we said before, are ones that you're going to come back to and look at, revisit, share new ideas on. But I think they're a really excellent start for what I'm going to present now, which is essentially moving into why we started thinking about health systems slightly differently than simply an organogram, a structure of hospitals and health facilities, and a little bit about the streams that we have moved into with this research. So, what is a health system? If you look at this, there's many different definitions, but probably the most prominent definition that's used today is from a report by the WHO, which was called Everybody's Business, Strengthening Health Systems to Improve Health Outcomes. And the timing of this report in 2007 was very important. So why do you think people were thinking about strengthening health systems in 2007? What was happening in the mid-2000s? Any idea? So there was health systems research was going on. There's a lot of work, for example, comparative work on comparing health systems around the world, performance, looking at performance indicators. But why does strengthening come in the mid-2000s? Why do you think?
Maybe not only because of it's like polio or something like that. Nowadays, like apart from that, every day we are seeing NCDs and mental health disorders. So if we have a robust system, so that can, from that we can reach all the health issues. Maybe from that's what the concept we call it as universal health coverage. Okay. So that may be the reason we started thinking because of that strengthening the system.
Okay, good. So there's two issues that you've raised. One is around universal health coverage, and the other issue is around emerging issues, emerging problems. For example, NCD, comorbidities, interactions across diseases. But what else is happening during the mid-2000s is that there's the rise of global health initiatives. Yeah, do you remember the Millennium Development Goals and the challenges of delivering priority interventions, whether it be vaccines or antiretrovirals, through the health system? So a huge amount of money coming in, certainly in the African continent, to deliver priority programs. So now that's already giving you a hint. We'll come back to why the shift to looking at health system strengthening. So when we talk about the health system, the basic definition that you find in this report is, again, actually very much comprising the things that you have already outlined in the diagrams. It consists of organizations, people, and actions whose primary intent is to promote, restore, or maintain health. What are key components? Some of them we talked about earlier, just before lunch. The health system goes beyond health facilities, so it includes preventive efforts, public health efforts, promotion, community initiatives. But it also includes, and I believe we only had one diagram doing this, social determinants of health. So water, sanitation, nutrition, also part of the health system. The health system also has multiple actors. So we're not just talking, and India is one of the best examples for a very multi-dimensional, multi-sectoral kind of health system. Not just government-run systems, but the private sector plays a huge role here. NGOs, communities, but also informal providers. So when I started working in probably the mid-2000s, when I used to come more regularly again to India, there was a lot of discussion around the role of RMPs, registered medical providers. And half of the camp used to say, these aren't real providers, they're quacks. They're unlicensed, they're unregulated, therefore we shouldn't really be doing much with them. And the other half said, we should. Why? Because they're the only provider available in some areas. And therefore we need to work with them, right? So beyond these kinds of actors, there are other actors that are relevant to health systems. And what do I mean by that? When we talk about a multi-sectoral approach, what other sectors would be relevant to the health system? Let's take an example. Addressing gender-based violence. What other sectors or what other systems come into play? Yeah? Anybody? Mental health, yeah, what else? Law, yeah. Criminal system, criminal justice system, and so on, okay? Similarly, when we think about prison health systems, okay, we often are looking at the intersections of the legal system and the health system. When we think about care, certainly maybe not in India so much, because in India, elder care for elderly is still very much in the hands of the children. But increasingly, in high-income and middle-income countries, we're looking at models of community-based care for older adults, which is at the intersection of social care systems and healthcare systems. So the health system, even though we can circumscribe it, certainly for some conditions, we're also invoking other sectors, right? The third point is that we are interested in the system as a whole. So as we said earlier, health outcomes are not just about medical interventions doing what they do best, but also about how we're going to govern the use of that technology. How are we going to finance it? Who's actually going to be there to use the new, whatever it is, diagnostic system for drug-resistant TB? And what are the models of service delivery? So the Vice Chancellor this morning was talking about digitalization and new interventions in India. And my thought, my light bulb question was, how is this going to be delivered? Who's going to do this? How are we going to be able to deliver this in a sustainable way? Yeah, so I was thinking about the systems questions. He was thinking about the technical systems issues, which are very important for making sure the technology works as it was intended, can it be implemented, etc. But as soon as you move into a real life system, a real world system, you've got to be thinking about, can we really implement this? Is it going to be feasible? So that's what we refer to by a kind of systems perspective. Okay, so this is just an example. This is a little paper from Health Providers' Perspectives on Integrating NCDs into Primary Healthcare in Thailand, mixed method study, and I'm just putting this up as yet another diagram. But what I quite like about this is it's a combination showing us both the institutions, but it is also showing something else in the right-hand bracket. What is it showing? Yeah, somebody? Go ahead. Anybody? Go ahead. You can just raise your hand and tell me. Okay. What are the things in the box on the right-hand side? What does it do for the diagram, in your sense? Connects things, yeah. Connects, so it's showing a relationship of some sort. What else? Sorry, you got to speak up. Functions, yeah. Functionality, something else. So relationships, functionality, and intersections, good. And some kind of hierarchy, yeah. There's a line of command. Okay, we can critique this framework. But again, I just wanted to offer it to you because I had no idea that you were going to come up with such brilliant diagrams. So I thought I would put this one up just as a start. Okay. So turning to health policy, because the course is not just about health systems research, it's also about policy research. So what is a health policy? Again, I'm going to give you a standard definition, which is that it's decisions, plans, actions that are undertaken to achieve specific healthcare goals within a society. That's a very broad definition. So when we think about the key elements, often, as you described very nicely in this diagram, group 4, it's about formal policies, so laws, regulations, national programs, which trickle down in the form of different kinds of guidelines or local level policies. It's about informal policies as well, and that's something that none of you mentioned so far, is that policy is not just about the stuff that's written down and, you know, and set in stone, or it's not just the guidelines that you have in draft form or in real form. It's also about the way in which policy implementation is influenced by power relations, lobbying, influence. So for example, how insurance schemes favor private hospitals over public hospitals. Okay? So this is also part of health policy, and health policy research, if it was only about the formal stuff, it would be very boring, right? Because when you see, for example, you know, a document analysis of policies, often it is just looking at, you know, at basically official speak, right? Because it is what is on paper, but what happens in practice we know is often quite different. And there's all kinds of mechanisms which contribute to reasons why policies are not really implemented exactly in the way they were intended, okay? It's also about public versus private sectors. So health policy affects both government-run as well as privately provided health care. So again, thinking about policies that regulate private hospitals and insurance, or indeed private providers. And there's a lot of debate around the extent of regulation that needs to be put in. But there's another definition here, which is from a very good website called the Health Policy Partnership, which says that, yes, if we stick with the WHO definition, that's a kind of standard okay definition. But this person says that policy is also a set of principles, ideas, rules, and boundaries that provide the foundation on which individual policies are structured, and it has a strong cultural component. For example, around whether individuals should be given more responsibility or whether private sector involvement is a good or a bad thing. There's always a moral evaluation of that, right? So if you are, you know, if you're in the US healthcare system versus the UK healthcare system versus the Indian health system versus the Chinese health system, you will have a different cultural expectation, a social expectation of what the health system should do for you and who should be doing it, right? So in countries which have a strong bias towards a private healthcare system, the US would argue that it has an excellent system in terms of the technology, the equipment, the infrastructure. But it also has something like 15% of people uninsured. So it's not an equitable system, right? Other issues around responsibility for health. You might say our policies on NCD care should be shifting towards prevention and a focus on lifestyle modifications. But some would say that's a moralistic stance. Some people are not in a position to go to a fitness club or change their diets or even stop smoking because smoking is the only stress relief for them, yeah? And that's very different than saying I'm going to concentrate my NCD funding towards kind of curative interventions at a stage when many would say it's already a bit late to intervene, all right? So just briefly, just to remember, so it's about the formal components, the formal guidelines and so on, but it is also about the informal and the extent to which social norms and values and ethical values play into our decisions about who takes responsibility for health. Yeah? Okay, so why should we study health systems? Why should we bother studying health systems? Because I think it was a very interesting question that you raised on this one. You said if there wasn't a community that had demands or that had preferences or that had health conditions, what's the point of a health system? So there was something in that diagram about the relationship between the demand and the supply, which kind of shapes the health system. So ultimately, why do we study them? Because they're the backbone of healthcare delivery. They determine how well people are accessing care, whether the most vulnerable are being reached. They determine whether you're receiving quality treatment or not, and ultimately whether you're attaining a fundamental goal of the health system, which is improved health, right? A well-functioning health system contributes to these goals. And now there's many, many different frameworks. We're going to look at some of them. But essentially, the goals are not so different. And they are generally expressed slightly differently, but they're all saying the same thing. First, a health system is there to improve health status. It's to reduce mortality, morbidity, and disability that is attributable to conditions that where you can intervene from a health system point of view. Again, it sounds straightforward, but it's not so straightforward, because there's always a question in terms of health systems, which we won't be discussing so much in this course, but around how do you make fair decisions around which interventions to prioritize, which areas of healthcare to prioritize, depending on your profiles, your epidemiological profiles, your projections, etc. So even though we say a health system is intended to improve health status, we might have very, very different understandings of which things we're going to prioritize. If you're living in Malawi, you expect different things from the health system than if you're living in Denmark, obviously, right? The second major point that health systems research is concerned with, or rather health systems frameworks are concerned with, is the fundamental goal of equity and access to essential health services. So not only do you want to make sure that the health system provides quality services that actually do act on different determinants of morbidity, but you want to ensure that people have equitable access to the system. The third is linked closely. It is to make sure that nobody has to gets into what's called catastrophic expenditure. So you don't have high out-of-pocket payments. Now, that is a very contestable one. So for example, when I first started working in India, I was always struck by this statistic that people would tell me, which was that 70% of people, regardless of socioeconomic status, seek care in the private sector. So they're willing to pull out a payment, okay? And it meant to me two things. One was that people saw themselves increasingly as consumers and had decided that private sector care offered them more options, or in fact that the public sector system, there was simply not enough trust or enough quality or enough faith in the system as a whole, which led to people using the private sector primarily. The fourth thing that you will find is this idea of responsiveness to people's needs and expectations. Now, responsiveness has been interpreted in different ways, but essentially it means that the health system conforms to a certain level of care, which is what people expect from it. Bit challenging, because you might say, should clients or consumers or whatever you call it, patients, should they be allowed to determine, should they be allowed to have a say on the responsiveness of the health system? Okay, so for example, in the UK, if you go, I think you have that in India now too, if you go to a GP, you immediately are offered the chance to rank the GP, yeah? So you go out and there's a little set of smiley faces, but it's not just the smiley faces. You actually get something sent through, or it used to be, not now, but certainly when I was there last. And you could basically put in essentially a ranking. You could describe how your experience was. Now, obviously, there's a lot of potentially subjectivity that comes into how you evaluate your relationship with a health provider. If, for example, I'm somebody who comes from a country where it's easy to get antibiotics over the counter, and I go to the UK and they keep giving me paracetamol and saying, go home again, I'm going to rank the service poorly because it's not conforming to my expectation. I want those antibiotics, why am I not getting them? And this happens fairly frequently, that people are unhappy with a system that doesn't give them a bag of medicines or an injection of some sort. Yeah? So this is an interesting question. What exactly do we mean by responsiveness? We won't have time to get into that, but it's just to mention it as another criteria on which health systems are evaluated. And the fifth is efficiency. So this sometimes doesn't necessarily feature in the health systems frameworks we will look at, but efficiency is obviously around how much am I putting into the system in terms of resources, and what am I actually getting out of it in terms of the outcomes? Is the system performing adequately in relation to the amount of the resources, the money, the constellation of health workforce, the equipment, et cetera, et cetera. So why else should we study health systems? Because policies shape health systems performance. So health policies, as we said, they often set, and we saw here, they set the rules, they set the incentives and the structures that shape how health systems function. They influence who gets funding and where it goes, resource allocation. They influence service organization and delivery models. So I mentioned earlier in my talk the shift, for example, in HIV care in the last 10 years has been very much towards models of differentiated or integrated care. And that means that we're looking more towards, for example, lower level health workers, that there's an amount of task shifting that goes on, which means that people who normally were not allowed to offer, HIV treatment are now able to. So, for example, not for HIV, but I'm thinking now for drug-resistant TB, for example. When I was working in South Africa, the discussion was very much about nurse-led, decentralized DRTB care. Okay, and prior to that, treating drug-resistant TB was mainly done in very highly specialized centers. So this was kind of a revolution, the idea that you could decentralize care. South Africa was also leading in terms of decentralizing HIV care. But again, those are interesting discussions, right? Those discussions around who should retain the power to do that kind of care. So in Belgium, for example, I had a PhD student who was working on PrEP delivery, which is pre-exposure prophylaxis for certain risk groups. And in Belgium, there was very strong pushback that this should be allowed to be administered by GPs, by general practitioners. So they wanted to keep it very tightly focused in the HIV specialist reference centers. And the same thing when I worked in Eastern Europe, in Latvia, it also has a very centralized system for management of drug-resistant TB. And when I said to them, but we have, DRTB care has been decentralized in many African countries, and they looked at me as if I was mad. Why would an African model work in our country? And I said, well, maybe it's time to look a bit further afield. But because of it's a post-Russian economy and a post-Russian medical system, so it's very, very medicalized. Anyway, so just to say that you have policies, but again, often those policies and those landscapes of care are what we would call path-dependent, which means that they have certain specific histories which have to do with how the health system was developed and evolved that now have bearing on what is deemed acceptable in terms of organizing services. The other thing that policies influence is health workforce distribution and retention. So I have another student who's working, for example, on health workforce reforms in the country of Guinea, which is a very poor country in West Africa, and he's looking at successive health workforce reforms over the last 20 years to see what difference they're making to malaria control. Access to medicines and technologies are also governed by different kinds of policies. And as we said, policies can be explicit or implicit, formal or informal. Some of the key questions, there's lots and lots of questions, and that is one of the things we're really going to do in this course, is we're going to support you in your ability to formulate good questions. But some questions are, why do some health policies succeed while others fail? Yeah? How does power and politics shape health systems' performance? And what are the unintended consequences of certain health policies? So you might have a health policy that is intended, for example, you have a policy around using or bringing in a new form of diagnostics, but because you didn't think through the systems issues enough, you didn't think about the health workforce in place, about the amount of training, about the fact that people would be resistant to using the new machine because they had been doing things in a certain way the whole time, and it just didn't take off in terms of an initiative. So often the research we're doing is trying to understand where's the gap in terms of a policy that looks very good on paper, but the implementation which is lagging. Yeah. So this is a book that I would recommend looking at. It's by a friend and a colleague called Dina Balabanova. She's originally from Bulgaria, but she was a colleague at the London School of Hygiene and Tropical Medicine with me. And they did some very interesting work, which is basically looking at a number of countries where the, the GDP is comparatively low, and the investments into the health sector and the health system are comparatively low, but they're performing highly. So good health at low cost. And the reason this title is quite catchy, 25 years on, is because this was published I think in 2018, but 25 or 30 years ago now, there was a report by the Rockefeller Foundation highlighting examples of countries, and indeed in India's case, they highlighted one state. You can probably guess which one it is at that time. This was about 30 years ago, which have sort of, in terms of their overall performance, meeting those goals that we talked about earlier, are doing particularly well. Which state do you think it was in India? Kerala, yeah, exactly. So interestingly enough, the original countries in the report were China, Cuba, Kerala in India, because it couldn't take all of India, just too difficult. And what was the fourth country? I can't remember. I honestly would have to look it up. And then 25 years on, they did the same exercise, but they realized that the country, the things had changed in terms of the stats. And obviously it's very difficult to really get comprehensive stats on health systems performance. But the countries highlighted in this report were Ethiopia, Bangladesh, Kazakhstan, and again an Indian state, but this time not Kerala. Which one do you think it was? Tamil Nadu. Okay. So anyway, I mean, these exercises, they're always contestable, right? Because you might say, yeah, they're performing well on this, but not so well on this, and therefore, et cetera, et cetera. They didn't take account of this. But that is very stimulating as a discussion, right? Okay. So let's go to the origins of health policy and systems research. In terms, historically, I think I mentioned my dad as somebody who would say that he was doing health systems work many, many years ago in the 70s. And he would argue with me when I first got into this field, he'd say, old wine in new bottles. And the reason why is that he was very committed to working at the community level, and he always, he would produce guidelines, tools for assessment, for understanding the performance of the health system from the point of view of the district health system. So you'd always say the district health system is the core component of the system that we should be looking at. And we should be looking at all kinds of relationships that, exist within that district health system, and it's embedded within a community. So this is back in the 70s, and it was actually work that he did in India many, many years ago in the Punjab. So from the kind of people who are now big in the field, they would say that it started around the mid-90s. And there was specifically the WHO that published a volume called Health Policy and Systems Development, an Agenda for Research, and shortly after there was a section of the WHO called the Alliance for Health Policy and Systems Research, which was grounded. So effectively they've been around 25 years now, and we're going to talk more about their role. But I would encourage you to look up their website. The Alliance website offers some bigger funding opportunities, although now I'm not very sure about how, with the funding freeze at the moment, how that looks. But it's a very useful resource in terms of finding reports, finding recent studies, and also getting your finger on the pulse of what are the kind of current global topics that are of interest. So before 1996, I would say that there's recognition that the field was quite fragmented. even though there were people like my father and many others who were already looking at health systems from a more comprehensive view, a lot of what was happening was reports on health systems performance that were very quantitatively oriented and very traditional in terms of measuring performance. And the existing bias in terms of the research that was being conducted was towards biomedical and clinical research. So really looking at whether systems were making a difference to specific health outcomes, how much they were spending, and so on. So that's all important work, but was kind of fairly limited in some ways. Health services research, which you might think is linked or part of health systems research, is actually a distinct branch, focused primarily on micro and meso level questions about the interactions between patients, providers, and service delivery organizations. And most of this work was conducted in high income countries. So it's only after, I would say, after 1996 into the 2000s where there's much more interest in low and middle income health systems. One of the things that was noted by the Alliance in this flagship report was that there was a lack of demand for evidence to inform decision making about health priorities and health system strengthening in low and middle income countries. And so what happened around the 2000s, which is why I asked you, what was going on in the mid-2000s, is that because of the significant increase in funding, in global funding that was available for vertical programming, TB, HIV, and malaria, it was recognized that we're not going to be able to deliver some of these priority interventions that Mr. Gates or Mr. Clinton or so-and-so came up with if we don't have a strong health system. So in fact, those ambitious goals that were set by the Millennium Development Goals report were not being met for maternal health or for TB or for malaria. And so we realized you're not going to meet these targets unless the health system is stronger to be able to deliver these interventions, to scale up antiretrovirals, to be able to implement new diagnostics. So these are just some examples of these flagship reports that came out. These are really worth looking at because they outline the trajectory in terms of health systems and policy research. Whoops, sorry. Oh, sorry. Something is going on with this. Yeah, so here, for example, you see the World Health Report is probably one of the first reports that talks about health systems improving performance and comes up with one of the first frameworks. This is the next one that is 2007, Strengthening Health Systems to Improve Health Outcomes, mid-2000s. And then we have a further evolution around 2012, which specifically introduces systems thinking. Okay, and that's a major shift in terms of how we look at health systems, which we'll be speaking about. And this is the report that I mentioned earlier. Okay, so let's look at some of these models and see what we notice about them. The first model I want to mention is the 2000 World Health Report model. So this is probably the first formal model that tries to look at components and functions and goals of the health system. So you can see on the left-hand side, there are some critical functions that the system performs. Oversight, creating resources, so investment, training of health workers, and so on. Delivering services, provision, and then financing, so the different mechanisms that are there for collecting funds, pooling them, and purchasing different things that are required for the health system to function. And on the right-hand side, you see again echoed some of the fundamental goals that we mentioned before. And in this case, they focused on three: good health, fairness or justice in terms of being able to access the health system and not in a way that leads to catastrophic expenditure, and this question of responsiveness to people's non-medical expectations. So here, responsiveness is really around, is the health system user-friendly? Are the providers courteous? Do they meet my non-medical expectations? Because it was assumed that patients or clients would not be in a position to evaluate the health services itself, right? Whether they're getting a good care or not. Just like the example I gave you, if I go there and I say, I'm not getting antibiotics, therefore this is a bad provider. That's not what responsiveness was about here. It was more about, they gave me this, they did it, they explained it well to me, I understood what it was, and I understood the decision taken, okay? So this was an early framework, and it captures some things which continue to be very important in terms of looking at health systems. This is a framework that is different in terms of it's the way it's conceived. It is a more dynamic framework, and it's known as the control knobs framework. So this is what the World Bank came up with in 2004. And I kind of like this framework. I know it's an old one, but I like it because it presents the health system. You see the goals again, they're the same, or slightly different: efficiency, quality, access. These are intermediate goals, actually, but they're leading to the same goals: risk protection, so financial risk protection; customer satisfaction, which is responsiveness, again; and health status. But here, which is kind of interesting, is they introduce this idea of control knobs, which you can regulate, you can move. So they're saying that within different countries' health systems, there are 5 things which are flexible. Yeah? So, for example, based on where I'm dialing my control knob, will give me a sort of, will give me outputs in terms of my intermediate goals, and in turn lead to my fundamental goals. So these 5 knobs are what? They're financing mechanisms. How do I collect funds that are needed to pay for the health services? And how the institutions that provide those funds operate. The second is the payment manner. So how am I transferring money from these institutions to healthcare providers? And how are those incentives being managed? The third is organization. What is the internal functioning of healthcare providers, and how are their functions determined? Are they competing with each other at what level, or are they coordinating? The fourth is regulation. So where and how does the state influence or impose on the actors that make up the health system? Okay, where are there stringent regulations set about what a private provider, for example, can do, or even within the public sector, what one can and can't do? And there's behavior, which relates to the ways that people, both users and providers, what they do in relation to how health and healthcare is influenced. So essentially, this control knobs framework presents, for me, a more dynamic view of the system, because it allows you to think about the way in which different countries' health systems, or indeed different states within India, might play with these knobs slightly differently. But it also helps us understand how and why certain interventions could be introduced to improve efficiency, to improve quality, and so on. Okay? So it's a complex framework, but you can see how you could start to articulate some questions. So if I introduce, stringent regulation of certain private providers with regards to their ability to manage whatever it is, TB, and at the same time I'm putting some other kinds of interventions at this level. How is it going to affect my intermediate goals? Okay, it's a bit abstract at the moment, but I don't want to spend too much time on this, because this is a general introduction to health systems frameworks. This is probably the most common framework that you'll see. This came about a few years later. So I personally like this one. As I said, oops, sorry. I'm just not using this properly, am I? I personally like this because it introduces that element of where I can intervene. But this is one that you definitely will probably, if you're familiar with any health systems framework, this is the one you will probably recognize. Yeah, and this is referred to the building as the building blocks framework. And what are the building blocks? Basically, it outlines 6 components of the health system, which together lead to intermediate goals. Again, access, coverage, quality, safety. I mean, we could have listed a whole bunch of other ones, right? Equity, efficiency, and so on. Actually, efficiency is a fundamental goal there. And in turn, we have, again, a recurrence. So one thing we see is that in all three frameworks so far, the fundamental goals are the same, right? Can you look at this and tell me what you think about this? So you see the building blocks: leadership, governance, financing, medical products, information, health workforce, service delivery. I will give you a hint that this framework has been critiqued quite heavily. Why do you think it's been critiqued? Rigid? Okay. In what way? Mm-hmm.
And when we talk about the left-hand side also, all the components are interlinked
Mm-hmm.
with each other. So that is not represented
Mm-hmm.
on the right-hand side also. So I think the adaptability and flexibility part is not represented.
Okay, good. So you said something about the components on the left-hand side being interlinked. Can you give me an example?
If we take like above the arrow, we are commenting about accessing coverage and access to coverage, and below arrow we are looking at quality and safety. So how does it connect? Means like if we look at the service delivery, health workforce and information, those are all comes under accessibility. Like what we call it as availability, acceptability and accessibility.
Mm-hmm.
Like so the first three, the top three things which comes under access to coverage, and the last three like medical products or financing and leadership, there it comes to the quality. Like they are the one, they are going to procuring the things, or they are going to decide the things, they are going to decide the quality of the things. So these like below three structures or building blocks, they are going to decide the quality. So by merging like those, the quality and safety by these three blocks and accessibility to coverage from the above three blocks, that gives, like we can see that improved to health and responsiveness from that access to coverage, and also from that like social and finance risk protection. Like if we take like any private or government sponsored health insurance scheme, that will give the risk protections means in healthcare it's a financial protection. Mm-hmm. And also that improved efficacy. Like improved efficacy in the sense when we have adequate financing or enough financing for the health system or existing or upcoming or whatever, maybe private or public, that definitely improves the efficacy of the system.
Okay.
That's what it's trying to convey, I thought.
Okay.
Thank you.
All right. So if I get you right, you're saying that essentially this doesn't really tell us about how specific configurations here are influencing specific intermediate goals here. But there's something else. Let's not look at this side for a while, and let's look at this and go back to your point, which is something about this doesn't sit well. What is it? If you could organize this differently, what would you do? Overlapping each other? Any other suggestion? Start with leadership and governance, yeah? Are they overarching somehow? Sorry, who said that? Okay. Yeah?
We'll start with leadership and governance.
Yeah.
Because will matters a lot in executing all the functions.
Mm-hmm. Okay, go ahead. Yeah.
So in this we are actually we are talking about the community, right? So all these building blocks will ultimately serve for the community at large. So that part is missing over here.
Okay, good.
So it will be,
Okay.
it should be people centric.
Okay, good. So you're raising different issues slightly, right? So the first issue that was raised by the gentleman was that this doesn't really clarify how these elements influence those intermediate goals. The second issue that was raised is that these building blocks are not all at the same level. Yeah? Some are overarching. Financing and governance, we might argue, are influence everything else. Yeah? And the third point I think that you were raising is something to do with the absence of the community, right? Okay, so there's another point, which is, for example, service delivery. Is service delivery possible without a health workforce, or without information, or without medical products, right? So there's something about the static nature of this that we should have some way of interconnecting this, yeah? But anyway, I have to say that this framework has stayed very influential. Yeah, it's still used very much today, so when people say I'm doing a health systems analysis, very often the paper or the document will report on these 6 categories. Yeah. Okay. So alternative interpretations that take, that would argue that we need a different conceptualization of the health system, would say that some frameworks emphasize we need to look at the adaptive nature, the social, the political of the health system rather than just technical functions. Others focus on specific aspects. So, for example, there was a very strong Lancet editorial some years back about high-quality health systems. And that put forward an entire framework based on quality. So the point that you raised, yeah? It's by Margaret Crook, and it's a very interesting framework. Others focus on things like needs, expectation, trust in the system, positive user experience. So this issue that you raised about the community at the center, which is very much in your framework as well. So progressively, there's been more of a focus to say the building blocks by themselves are not so interesting, but we need to understand where do people figure as providers, as managers, as patients, as communities that are placing demands on the health service. So this concept of hardware and software came about, yeah? And by hardware, again, it's actually in one of your diagrams, you talk about capacity and capability. I'm not sure that's hardware, software, but in some ways it's starting to get there, I think, yeah? This idea that there's structures, there's funding, there's workforce, those are the blocks, right? That's the hardware, the technology, the equipment, the infrastructure, how much space do I have? And the software is all the things that make the system run, in the sense that you have translation of guidelines into norms. You have relationships across the system. Some relationships are more hierarchical, some are more collaborative, some are conflictual, and often those relationships are determined by things outside of the system. Gender hierarchies, caste hierarchies, age hierarchies. Okay, just thinking about the relationships of ashas with their supervisors, or nurses with mainly male doctors, et cetera, et cetera. So there's all kinds of dynamics that play into how the system is run. And that's really something that's emerged in recent health systems thinking. So this is a health systems framework that was produced at ITM as really it took the form of a critique of the building blocks framework. It stays with the same kinds of, components and functions, but it's adding arrows, and it's also clustering things differently, yeah? So this is known as the health systems dynamics framework. I'm not saying it's 100% either, but I'm just showing you a progressive trend in terms of how we think about health systems. So here you do have the population featuring, right? You have the resources clustered here. So this is your capacity or capability? Capacity, right? This is your capacity. You have leadership and governance are overarching. Service delivery is dependent on this. and then you have outcomes, intermediate outcomes of the system, your program targets or whatever, and ultimately your goals, which are still the same. Health, good health, responsiveness, financial protection. Okay? So that's all I'm going to do on frameworks. I can send you a list of, or we're going to do a list of resources for you anyway if you're interested in these frameworks. I think it's useful to keep at the back of your mind because when we look at all of them together, we can say that they all have their individual strengths and we might use them to, conceptualize our questions or refine our frameworks and so on. I don't know if Solomon or Abai want to add anything in terms of your own work and how you've applied frameworks.
So basically in my work, the PhD thing that I did, it was all about relationships. Mm-hmm. So people are talking about community is not there or it's not people-centric. So it was more individual focus and that's how the whole PhD ended up drawing a framework. Mm-hmm. But then coming back to that health systems building blocks, we have, like on one side we are talking about the blocks and the other side we are talking about the outputs. Mm-hmm. But whole of the process in between is where my framework was trying to contribute in terms of the whole relationship aspect. Because a health worker, mm-hmm. if he's not recognized within the system, he won't be able to deliver mm-hmm. the outputs. And there the whole emphasis on the software mm-hmm. came in. So that's how I have looked at the framework that has emerged from the thesis. Yeah.
Great. Abai, do you want to add anything? Or? Okay. All right. Okay. Okay, so moving on. Okay, now we're going to look at something different. We have basically looked at frameworks, but now we're going to look at types of health systems research, or types of research that you might think are health systems research, but you're not quite sure. Because you might be still saying, and that's completely right, you're only on day one, is what exactly counts as health systems research, right? So let's think about different kinds of research that are used to improve health systems. And there's a very interesting paper by John Rem, an old paper, 2010, but he basically distinguishes between three types of research that are used to improve health systems functioning, yeah? And the third is health system research. So I think it's really important to get clarity on the differences. But I have to say to you that there are many people who would argue, oh no, operational and health implementation, that's still part of health systems. It can be, but I think just being very clear, why are they different? And why is health systems research distinct is very important for me in this course. So when we talk about operational research, so this was very popular maybe 20, 30 years ago, okay? This is at the level of the program. So this is your TB control manager who looks at the program and says, something's not working. My gene expert machines are standing there collecting dust. Nobody's actually using them. Well, no, he's not saying nobody's using them. That's a different question. But he's saying the machines aren't working, and therefore we're not achieving the throughput that we should be. So the operational issue is very focused on this isn't working, and therefore I need to fix it. Yeah, it's this operational issue of a specific health program. The user is usually the direct healthcare provider or the program manager, and it's usually very locally focused. Yeah. Implementation research is different. Implementation research is examining how and when you introduce a new intervention into the health system, how that intervention is implemented. Is it implemented in the way it was intended to be implemented? Is it feasible or practicable in the way it was intended to be? Or are there challenges around implementation? So this is often for program managers, but it's also for research and development managers. Why? Because they're interested in developing new products that are going to be used in the system. And if they're not being implemented in the way they were intended, they've got to change or refine the product or refine the strategy. The third area of research is the health system. And here we are really looking at a research piece that has effects some or all of the building blocks of the health system. Yeah, so we might pitch our question at the funding level. So how does the vagaries in donor funding affect my health workforce retention for this program? Or you could be looking at something to do with the health information systems. So at a broad scale, how does digitalization in India impact on community health workers' ability to do rapid screening of whatever it is? Yeah? So remember, the operational issue is linked to the technology often. Yeah? Do my, whatever it is, my tablets that I'm going out into the field with, yeah? You're giving the ASHAs a tablet, you want them to do some screening. Are they actually working? Are the tablets working or not? Or are they running out of charge or whatever it is? That's an operational issue, yeah? The second issue is implementation. My strategy that I want to implement to improve NCD screening is to give ASHAs a tablet, to tell them to report so and so often. You have a strategy. Is that working? Is that strategy working as it was intended? That's my implementation question. And the health systems question is a bigger one. So what is the motivation, or how does introducing a new technology change the status of the ASHAs? Okay, it's a big question, right? Because it's about health workforce motivation, capacity, resources, technology, lots of different things. Okay? Let's look at this again, just because I want you to get absolutely clear on this. So, in terms of focus, scope, and an example. Operational research, I'm looking to improve the efficiency and the effectiveness of a very specific program. It's addressing a practical, a short-term challenge, optimizing a supply chain, improving a clinic workflow. Queuing system is another example, okay? When we did some work in South Africa looking at nosocomial transmission of drug-resistant TB, we realized that people getting congested through the queuing system and the waiting spaces was a big issue. So that's an operational question. How do I change my appointment system so that I don't get this rush in the waiting rooms, right? An example is studying ways to reduce stockouts of essential medicines in a district hospital, okay? Your implementation research is to understand and address barriers to successful implementation of a health intervention. So you're looking at the interaction between the intervention, the health system, and the context, because you want to make sure that your intervention, which maybe has gone through some kind of clinical trial, they say, yes, this is excellent, this drug is going to work, it's going to change, do wonders, but you're actually looking at how this is going to work when you implement it in a real life setting, yeah? So you're investigating, for example, why frontline workers are facing challenges in adopting some new guidelines. In principle, your guidelines look excellent, yeah? They look excellent, they're going to make a huge difference to malaria diagnosis. In practice, the implementation of those guidelines is not delivering. Why is that? Okay, that's your implementation research. And the third one is your health systems question. So broader structures, policies, dynamics. Takes a holistic approach, like we've said before, to understanding governance, financing, workforce, power relations. And here, for example, the example is how does health financing affect equity and access in the health system? So, for example, if you introduce free, let's say, free services for maternal care, how's it going to influence uptake for vulnerable populations, for example? Okay, so here's again a nice diagram. Sorry, this is like 3 slides on the same topic, but I just want to hammer it into your heads that there is a big difference in these 3 things, okay? But the diagram here, you can see program, small level, slightly bigger level, even bigger level. And this is kind of thinking about utility, yeah? So your operational research is always going to be very, very specific to the program, okay? Whereas your health systems research is going to be broad, because you could technically use the same question that we just had and implement it in another country, right? You could be looking at the same types of questions, provided the country's system is similar. Okay, so I hope that's clear. Any questions on that? Yes? Yes. It depends on you. Okay. We'll just finish 2 more minutes. Yeah. Yeah. Go ahead.
There is one research question came into my mind. Like,
Yeah.
for example, we want to search about that, are the ASHA's worker overburdened?
Yeah.
So we do time and motion studies or work sampling. So based on that, whatever the results comes out, so based on we give recommendations also that we need to, based on the working hours, what we have to do, we have to divide the working hours so they do not get overburdened. So do I decide on the basis of the research question and or I say that is an HPSR area, or should I say that it's an implementation study? Or based on the discussion, if I say it is an implementation study because I'm going to do work sampling for them, and based on the recommendation, I'm giving recommendations at the higher, at the policy level recommendations.
Yeah.
So how do I categorize it? So it's very difficult for me to understand as of now.
Okay, so I want everybody to focus on this question. So the question is, are ASHAs currently overburdened? Okay, what would make it an operational question? Because you could do it at 3 different levels. But it depends on what you're measuring, okay? So what makes it an operational question? Exactly. Okay, so if you say, my strategy for ASHAs is I'm looking at a specific program and I'm now going to assess for each of the programs they're tasked with. Let's say it's family planning, immunization, something, something. And I'm going to go and look at how many hours are being spent on this program in terms of their daily, whatever it is, inputs. And I'm going to look at that number against what it's supposed to be. That's for me operational. Because at the end of the day, I'll say, you know, in order, my theory was that in order to achieve optimal performance, ASHA should not be working more than 6 hours per day or whatever it is. I'm just making this up now, yeah? How do I make it into a implementation question? Yeah?
If guidelines suggest ASHA should not work more than 6 hours a day, if that is the guideline, then I can maybe research. Or my question will be, then what are the problems they are facing, why they cannot stick to the guideline?
Mm-hmm. Good, excellent. Exactly that, okay? So your guidelines say, this is the amount of time that we anticipate that they would be working on family planning, counseling, or whatever it is, okay? The operational thing is to assess, are they spending more? The implementation research is probably looking a bit more into the reasons why, okay? Because you have a strategy, you have the intervention, not really an intervention, but in some ways it is, because you're saying in order, everything that is in the health system that is aimed to improve quality, access, something is an intervention. So if you say, if ASHA spends so and so much time on family planning counseling, so and so many women and men will be more informed about family planning, whatever. You have some idea of what it's supposed to do. And looking at why your strategy isn't working as intended is the implementation question. How do you turn it into a health systems question? Or could this be a health systems question if you're looking at why are ASHAs overburdened? Any idea? Mm-hmm. Okay. Okay. Interesting. Okay. Okay. Good, that's interesting. So very, very good point. Both points are excellent. So the first point is, sorry, I'm starting to get jet lag, so I'm forgetting what the first point is, but it was a very good point. Just remind me? Quality of the work. Yes, the quality of the work. So basically the question is, how does, to what extent does the excess burden of working hours on ASHAs impact on quality, safety, et cetera outcomes? I think if you try, I mean, I don't have a right answer because this is an example that's coming off the top of my head, but essentially you're looking at the impact on the system more broadly, or as you said, if the ASHAs are overburdened in terms of their hours that they're putting into family planning, what impact, what knock-on effect does it have on other parts of the system? Okay? All right. So going back to what HPSR is not. So what it is very clearly not is it is not biomedical or clinical research. So your basic scientific research looking at measuring prevalence of diseases, assessing effectiveness of XYZ vaccine or drug, or looking at efficiency of a drug delivery, etc., that's not health policy and systems research. That is basic clinical research. It's also not epidemiological research, strictly speaking. You could embed a survey, but a straight epidemiological research which looks at the prevalence of disease is not health policy or systems research. It's also not demographic research. Okay, so trying to understand, for example, the impact of migration from another country in terms of, disease patterns or something like that, or looking at changes in the age of marriage and the impact on use of contraception, that's not health systems research. Okay? It's also not health technology assessment. So trying to understand, even though this is where it gets a bit tricky, because you might say, well, this sounds operational to me. So in fact, something here could be operational research, right? Because you're trying to understand, is my treatment making a difference? Are my diagnostics making a difference to the number of people that can be diagnosed within a certain period of time? Is the technology working as it should? So those are sort of operational questions. We wouldn't include them under health systems questions, yeah? It is definitely about, as Solomon gave his example, it's about systems, it's about relations, cross-cutting factors, it's about performance of the service and the system, agenda setting, agenda policy making, policy implementation. It's trying to make sense of how people seek care and how they engage with the health system, and it's understanding how services, programs, and policies can be improved. Okay, we're going to do this slide and then we're going to take a little break. So what's important in terms of what we've been discussing so far, we have so far started to think about what a health system is. We've looked at different ways of conceptualizing the health system, and we have tried to distinguish what types of research there are and which we would say are health systems research as opposed to operational or implementation research. The implications of understanding the system as a set of interrelated components means that the field is really concerned with how societies organize themselves, achieving collective goals, different interactions in the policy and implementation process. And as we've said, that's interdisciplinary by nature, that you would have seen in the reading of that first chapter. So lots of different disciplines involved. I've just put together a project which also involves geographers and historians, because we're trying to map geospatial patterns of access. And we're also trying to look historically at histories of migration due to labor exploitation during the colonial period in the two countries and how they impact on mobility patterns and the implications for the health system now. That's in two African countries. And again, it's about a comprehensive picture. How does the health system respond and adapt to health policies, and how do health policies shape and are shaped by systems and determinants of health? Okay, I'm going to leave you with this diagram so we can have a 5-minute tea break. Is that okay? And this is probably a diagram that came around 2010. So again, big change from the previous diagrams. What's included? People. Okay. It's a bit simple, so it's not terribly sophisticated. I mean, your diagrams are much more sophisticated, right? But at least there's some people in the middle. And there's overlaps. Yeah, there's acknowledged overlaps. Okay, so I'm going to pause it somehow. I'm not sure how to do that. Okay, so we're going to continue. I know you must be getting a bit tired of hearing about frameworks and stuff, but I think this, I'll tell you, this is the most framework-heavy part of the week. We will ourselves be designing lots of frameworks, so they'll be constantly encouraging you to think about things conceptually. But I wanted to make sure at least when you see one of these diagrams, you're not floored by it. At least you know where it's coming from, okay? So this is not really a framework in my view. This is a kind of simple way of showing something that happened around 2010, which is the introduction of approaches from systems thinking. And here the idea is that we need to look at the health system as a system. And what exactly does that mean? It's the idea that if you think about a system, a bicycle is a system, a respiratory system is a system, right? It's all about having to have components that work together in order for the bicycle to move or for you to be able to breathe, right? So in the same way, the idea of the systems thinking in health systems was moving away from isolated blocks or functional inputs to this idea that everything is interconnected, and we cannot really look at one component without considering what's going to happen in other components. So that also helps determine the HPSR research questions. It is you're always thinking about things in terms of their impact on other aspects of the system. So you're examining how things are connected and how they connect in the sense of an entity, the whole system. The methods and the theories in systems thinking are designed to address complex problems, and we're going to talk about complexity more excuse me, as we get along in the course, because we'll come back to complexity in terms of understanding contextual factors that have bearing on health systems functions, but we'll also come back to complexity when we think about analysis. What makes something complex? A complex problem is where you have multiple interacting agents within a changing context. It means that it's impossible to look at how things happen in a linear way. It's non-linear and it's adaptive over time, okay? And we'll think about that. But basically, if you think about most health systems interventions, so for example, something that you introduce which is a provider incentive, or it's even a new technology, it is complex. What makes it complex? Because as soon as you introduce a new technology, it's not about that technology working by itself in isolation. You're going to have people who believe in the technology, who are going to use it, who know how to work it, and who use it, make the right decisions about when to use it. Yeah, so immediately there's complexity around the feasibility, the practical, the operational aspects, and so on. So most interventions, I would say, are complex, but there are simple interventions. For example, when you say, I'm going to change my drug regimen, that's relatively simple if it's very clear who's going to administer that drug regimen. So I'm changing my TB drugs, which used to be so and so many months, down to a shorter regimen because this is less toxic for the patient, et cetera, et cetera, et cetera. So that's a relatively simple intervention. But anything that is impacting on human behavior or the interaction of humans with technology or equipment or whatever is actually a complex intervention. So another feature is that most global health issues are recognized as complex problems, and they need some kind of model or framework. So in your case, each of your groups is going to be working on an issue which is quite complex, and you're going to be thinking about a framework to conceptualize that problem. The other assumption is that systems behavior is governed by principles that can be observed and formulated. So we agree that systems can operate in unpredictable ways, but we think that with policy and systems research methods, we have ways to document what's happening and why it's happening. So systems thinking basically involves shifting your attention from individual parts to a whole, from objects, to relationships. So in terms of the object, again, the visual image you should have is a machine, a machine that's introduced to screen better, or a tablet that's introduced to do something. You're not interested in the object, the technical capacity of the machine. you're interested in what it does to the relationships between health workers and managers and researchers, etc., who would like to see this work in the best optimal way possible. From structures to processes, I would say we're interested in both structures and processes, but the interaction between. From hierarchies, like those, to networks. So the next step in your diagram would be to say, okay, so this is your traditional hierarchical structure of the health system. But in systems thinking, we're more interested in the dynamic interactions that cut across those levels, those hierarchical levels. Because some people are able to bypass the system and jump forward or backward, and others aren't. So what are those informal gatekeeping mechanisms? We're interested in moving from the rational to the intuitive. So by rational, in standard health systems performance analysis, there is an assumption that, there's a kind of economic thinking that dominates our understanding of performance. Whereas in systems thinking, we understand that human behavior is, we're not robots, right? We don't think like the economic man or woman always, but we have norms, we have values, we have subjective reasons why we do things the way we do. From analysis to synthesis, and from linear thinking to non-linear thinking. So now we go back to the macro, meso, and micro. I talked about this already this morning, but this is just to resume. In the reader, you will see that this is kind of your diagram for the different levels at the global, national, at the domestic, the local health system, and the micro level, which is concerned with individuals. And we again spoke about the fact that you can pitch studies at different levels, but you can also do a micro level study with policymakers because it depends on the focus of the study. So we won't go into that too much more. I just wanted to show you, again, this is a kind of organogram, organization of the Slovenian health system. And here, what I found interesting about this one, I'm always going to show you different diagrams because the way people conceptualize the health system is that this diagram looks kind of standard and a little bit boring initially, but actually it brings in people and it brings in some things around process. So it is telling you also something about, remember the control knobs framework. So it's introducing aspects of the control knobs framework into this diagram because it's telling you who has the power to regulate whom. Okay, so let's just spend a little more time on the macro, meso, micro. You can analyze health systems at these three levels, and at each of the three levels, you, for the most part, are concentrating on different actors, structures, and processes. So in the macro level, we're looking at national global policies, financing, governance, and the kind of key actors here are governments, organizations, regulatory bodies. So, what does the WHO, new policy on community health workers, what impact does it have on, India's changes to whatever, X, Y, Z. So that's a kind of typical macro level study, or a comparative policy study is a macro level study. The meso level is organizations and networks implementing policies, so hospitals, insurance schemes, district health authorities, and the micro level is really that interpersonal interaction, different kinds of health workers, right? Here's some examples of questions, because I think it's always helpful to look at an example. How do national health insurance policies shape access to care for marginalized populations? It's a macro level question because you're looking at a broad policy and how it's and what it means for access. It's not telling you anything yet about the methods because you could use very different methods to address this question, right? The meso level, how do hospital management practices influence provider motivation and patient outcomes? So the hospital has some policy of rewarding, paying out a bonus to facilities that are performing better. How's that impacting overall on provider motivation? And then here, micro level, how do informal provider-patient interactions shape antibiotic use? So that's quite interesting, right? Is looking at the level of, say, drug shops, pharmacies, or providers. Does the relationship between the provider and the patient make a difference to how willing the provider is to hand over antibiotic prescriptions, even if it's not warranted. And we've seen that very often, that the way antibiotics are prescribed or handled often has to do with gatekeeping mechanisms. So again, implications for health policy and systems research is we're looking at the interconnections, we're highlighting the social and the political, we're looking at complexity, focusing on micro, meso, macro, and usually we're starting from a model of the health system to identify the problem. And we're going to spend tomorrow, after tomorrow's recap, we're going to spend time on how do you go about identifying a problem. So for many of you who want to do PhDs, you might actually be struggling with identifying a good problem that you want to start with. You know AMR is a problem, but what is your question? Yeah? So we're going to spend time on that. So what is the problem? How do I set priorities around the problem? And how do I formulate the aim? And yeah, we use a holistic approach. Okay, we're going to stop there. But we've already had our break, so no more break. But what I was going to give you as the last thing of the day, the next 5 minutes, is I want to give you an example of a systems project that we conducted in South Africa, because it really illustrates the interdisciplinary nature, the holistic nature of a problem, the micro, meso, macro level, and also getting at different kinds of questions and using mixed methods. So this is a project which is, first of all, okay, let me just quickly go back and just tell you that also what's interesting is that this idea of applying systems thinking is becoming definitely more popular in public health in high-income countries. So I'm just highlighting some recent documents. Health and Social Care in the UK, again, introduced this notion of a whole systems approach about identifying various components of the system, assessing the nature of links and relationships between each of them. So this is just, I'm going to give you a bunch of examples that show you that it's becoming common currency, which, as Solomon and Abai know, it certainly wasn't 20 years ago, right? Another example is from Public Health Scotland. It's a country that I lived for more than 10 years, and here they're using a whole systems approach to apply systems thinking to better understand public health challenges and identify collective actions. And I believe they have focused in on one area, which is obesity, as one of the areas which is very, it can kind of be addressed through a whole systems approach. Another one, sorry, these are all UK examples, but I think they're really forward in terms of bringing these kind of approaches to public health. This is one on mental health, mental well-being. And then the last one is, this one is from the EU, a systemic whole school approach to mental health and well-being. So again, bringing in systems thinking, a systems approach to public health issues. So I'm going to give you an example from our own research. The background, this is the Umoja Umuhle study. Umoja Umuhle means a breath of air, and it's essentially looking at infection prevention control for nosocomial infection. So basically this is what happens when you have transmission of drug-resistant TB within clinics. That is as a result of the transmission patterns or risks within the clinic itself. So what we were looking at here, the problem was we know that there's a high burden of tuberculosis and drug-resistant tuberculosis in South Africa, but what had been neglected is really understanding that health facilities themselves, there had been so much emphasis on community burden that nobody was really looking at what was happening in the health facilities. And these are really neglected sites of MTB transmission. And also recognizing the fact that health workers are at high risk of occupational acquisition. And that in fact, one of the things that was driving this issue is a major gap between policies and practice around infection prevention control in health facilities. Now, obviously this project was conceived before COVID, and you can imagine during COVID and after COVID, there was a lot more emphasis on airborne transmission, right? So things may have changed. I mean, mask wearing became much more common than before, thinking about ventilation and so on. But at the time when this project was conceived, which was about 5 years ago or 6 years ago now, there was really a recognition TB infection control is a problem, and often health workers were blamed, yeah? So it was usually health worker non-adherence. They weren't wearing the masks. They were sitting in rooms where they had the air conditioning on but no ventilation, etc. So a lot of blame placed on the health worker. So these are elements of TB IPC. They refer to a hierarchy of controls, which just means that there are different kinds of measures that are adopted to reduce the risk of transmission. They include administrative measures, environmental and respiratory protective measures. So by administrative, we mean, for example, how do you decongest a waiting room? Yeah, you introduce maybe a queuing system, an appointment system, but basically you want to reduce that congestion in a space where you might be bringing patients together, some of who may have, as of yet, undiagnosed TB, right? So administrative measures refer to changes in organization of services. Environmental have to do with introducing measures that have bearing on the actual quality of the air and the flow of the air. So what's called a whirly bird, which looks like that, but it's something in a health facility. It is about your construction where your windows are, policies on keeping your doors open, etc. And respiratory protection is essentially your N92 masks. So these are intended to reduce risk for staff and patients by reducing the exposure and transmission, and they're usually made visible in standard practice, so masks, gloves, guidelines, and so on. Now, basically what we said is that the core components of IPC programs, according to the WHO, they talk about guidelines, education training, surveillance, and they talk about this idea of the enabling environment. So what is the environment that will support adherence to IPC guidelines? This is a general IPC guideline one. And they talk about workload, staffing, bed occupancy, built environment, materials. So these are very structures. Yeah, they're about how many beds are occupied, how many staff are in place, what does the construction of the building look like. But what we said is that actually this enabling environment didn't take enough account. It focused mainly on the material components, but it didn't really take account of practice or behaviors or relationships. So the social infrastructure, the enabling social infrastructure, was less visible. So our aim of this big project, this was a £2 million project which ran over 4 years, was to look at the social, the biological, and the infrastructural dynamics of nosocomial transmission of DRTB in 2 South African provinces with the aim of informing health systems interventions to improve IPC for TB. So what was our HPSR approach here? It was comparative. We were looking at different provinces. We were differentiating facilities in terms of their age, their size, their catchment area, because we thought that might have bearing on the TB load, but also on the facility running itself. Our research was contextual. We were trying to situate policies, processes, and practices at the clinic level within the structure and the functioning of the whole system. So what else was going on? Not just TB, but what were the policies around, for example, chronic care, where the medications, were being picked up, or what was the flow of services that might influence the level of congestion in the facility. Complexity, TB IPC was seen as a complex intervention with many interacting components, and the project was interdisciplinary, so triangulation of different methods, perspectives, sources of data on IPC. So these were our 6 work packages. The first one was an analysis of IPC policy, the history of IPC policy in South Africa. The second one was an epidemiological study. It was a prevalence study nested within this health system work. So this was looking at what is actually the burden, the prevalence of nosocomial transmission. The third was a study of clinic design and work practices, so very much looking very closely at what does the space look like, where are the windows, how do people move through this space. And the fourth was about healthcare worker and patient ideas and practices. So how did people feel about wearing masks or opening windows in a country where it's so hot that you actually don't want to open the windows. You want to keep them closed and put the AC on, even though it's not great for circulation, right? And all of that information led into 2 packages which were around designing an intervention. So one was coming up with systems intervention. So what did we need to change in the system? Infrastructural aspects, patient flow aspects, waiting times, all the different kinds of interventions that would be possibly have an impact on nosocomial transmission. And we had a mathematical modeler who actually looked at how these interventions, how they would project onto the numbers, and then we also looked at how much these interventions would cost. So this is a very comprehensive project in terms of its questions. So again, just taking us back to the micro, meso, macro, here you can see those packages, those questions at the different levels. Micro level, day-to-day working practices within clinics, how people understood risks and so on. Meso level, we were looking at transmission patterns. Now you might say that doesn't sound very health systems, but it was situated at the meso level because we were looking at it at the clinic-wide, and we were looking at organization of care, and then at the macro level we were trying to understand how policymakers had progressed with this discussion. So one interesting thing in South Africa is the AMR people and the DRTB people are separate. They don't really talk to each other, which is crazy because DRTB makes up 25% of AMR, but it's a separate field. Okay, so I want to say that this was not without challenges, okay? And this is the message I want you to take away. Not the only message, we'll see what messages you have, but for the end of the day is to remind ourselves that health policy and systems research is very interesting, exciting, and challenging, but it's a big step, okay? Because you're forcing, it's like a forced marriage, right? We were really in a forced marriage in that project because, I mean, the amount of arguments I had with there was one person who was ultra focused on ventilation, that's all he did. He's a ventilation specialist. So CO2 measurements. There was another person who was only focused on waiting times, who wanted to click every time people went in and out. I said, but surely it's not just about clicking numbers, it's about why are they moving around? And they said, no, I'm not interested in that. I'm just interested in taking account of what is the patient flow. So all those specialists had to sit together. So the team itself had very different perspectives as to what is compromising IPC here. Yeah? What is being investigated? What is our focus here? What is going to make the biggest difference? And it led to very different understanding of what was a valid source of knowledge about the problem and how to collect the data. Also different logistics, different pace. Yeah? The qualitative researchers insisted that their ethnography of facilities would take 3 months. Everybody else was ready to throw them out of the team because they said, no, you can't afford 3 months, no way. And the ethnographer said, no, okay, fine, 2 months, nothing less. So you can imagine, yeah, big arguments. And also the research participant dynamic. So the more social scientists were very cautious about the ethics, clicking people in and out or whatever it was. And the quantitative researchers, I mean, this is slightly stereotyping, but they were less bothered with what they thought was, okay, maybe not such an ethical issue. So different discussions about what was permissible and not. Lots of challenges in bringing different types of papers together, a need for frequent discussions, reaffirmation of the value of different observations, and dissemination for different audiences. But I have to say, it's probably one of the most successful projects I've worked on. So if you look up this website, you'll see that there's, I think, 26 papers published from this project, spanning the full range of very narrow stuff on ventilation, and then, very rich ethnographic content, and then there are a couple of editorials which try to bring things together. So it's a nice example to end on for today. I hope you enjoyed the first day, and I'm sorry we were off a little bit with timing, and I apologize to our film crew for interrupting many times and being a bit hopeless with the slides movement. But I really was very, very impressed with your participation so far and your diagrams, so I'm looking forward to more. All right.